Thank you very much. Thank you for the invitation to come, and particularly I want to highlight the students who came this morning for the examination, and thank you all for your contributions and for your dedication to being the future of nuclear medicine here in Pakistan. I'm not going to talk about something that's too complicated, and it's the kind of test which many centres will be able to do with simple techniques. So I'm going to talk a little bit about SPECT-CT in pulmonary embolism. I don't have any disclosures. I'm too old for anybody to take any notice of me. It's wonderful. So we're going to look at just what we tend to use for the investigation of pulmonary embolism and how that has evolved from planar towards SPECT-CT, and just a couple of little slides on some new areas that are opening up in SPECT-CT pulmonary perfusion imaging. So, to many of us, VQ lung scanning is a standard technique. It's something we know more about, and we use two agents to do ventilation and perfusion. The perfusion we normally, university now use technetium MAA, but ventilation agents differ. So some places are very rich and they can afford krypton gas. I haven't put xenon down, I'm so sorry. I'm not realizing quite so many people from North America here, but a gas such as krypton. But most people are using some form of either aerosol or a smoke-based system with or technogas. So I did mention xenon, but because evidently it has safety issues, we're not allowed it in Europe. Now, new work with SPECT and SPECT-CT might alter the choice that we would have of those agents that are available, because what we need for a SPECT study is a good count rate and a good stability. We don't want the agent moving during a 20-minute acquisition, for example. Let's start off with krypton. Now, I suspect, unfortunately, many of you may not have had experience with krypton 81M. You get it from a rubidium generator. It has quite a high energy gamma ray, which means that you can do simultaneous acquisition with the technician. But what you need to do, of course, is you need to continuously supply it. So effectively, you strap the patient to the generator and you pump through either air or oxygen so that the patient will breathe that in. The radiation protection is very simple, because by the time the patient breathes it out, with the 18-second half-life, it's all disappeared. And it's very good with SPECT. I'm just going to show you some planar images first. This is actually with krypton, and you can see very nicely, you get a nice image. So the top set of each row is the perfusion, the bottom set of each row is the ventilation, and you can see these are nicely matched. You get nice, crisp and clear imaging. What other agents? So most people, if they're going to do ventilation, will be looking at trying to do something that's like an aerosol. Now, they're cheap and easy to use, but the finer the particle that you use, the better the penetration into the small peripheral airways, and also you tend to get better stability because it stays there for a little bit longer. Because what happens is with these aerosols that they normally are moved back into the central airways and then brought up and swallowed by what we call mucociliary clearance. In fact, some people use that as a test of mucociliary clearance. But the residency for most of these aerosols is long enough to be able to do SPECT, even though it's not as stable as you would wish. So how do we do it? Well, it's basically a variation on the nebulizer that many people may have used or given to their kids for asthma when they have salbutamol. You basically have air that is twisted through a fluid, and it produces a fine aerosol, a bit like a mist, which the patient breathes in. Now, there are some complications because what you're breathing in is radioactive, so there needs to be some additional stuff around in terms of shielding and trying to make sure that the mask fits closely to the patient so they don't spew radioactive DTPA all over the room, and more importantly, the gamma camera in some ways. There is some issue that in patients who have, for example, smokers or people who've got airways disease, you can get clumping in the major airways. But the residency tends to be about 20 to 25 minutes, which is long enough to get a reasonable SPECT study. The only problem is, of course, that we tend to have to do that before the perfusion, because we need to get that to clear before we can give the MAA. So you then end up doing a ventilation on every patient. So radioactive smoke was invented in the 1980s in Australia, and it uses a DTPA, and what it is heated very, very quickly in a platinum crucible to a very high temperature, about 1300 degrees centigrade in a flash heat. And this produces something called a C60, that's a carbon-60 buckyball, and that contains the actual technetium, and these buckyballs are very small and they can be breathed in very well. And they again use a sealed system so you don't get the stuff to spew and escape everywhere. So the technique is fairly simple. You put some DTPA in the platinum crucible, you then heat it very, very quickly. It produces a very stable smoke which you can then give to the patient. And these bucketball smoke, they stay in the lungs. Some of them are breathed out, but some of them are cleared by, again, mucociliary clearance. The clearance is a little faster than it is with the aerosols because it's not so dense. So you can often do the perfusion imaging in about 15 minutes after the ventilation instead of waiting an hour or two. Now, if we do some imaging, this is some imaging done with Technogas. It looks just like the krypton. And again, the upper one is the perfusion and the lower one is the ventilation. You see, I'm still in examination mode here. And you can see there are multiple defects in perfusion with normal ventilation. And I think all of us will be confident in saying that will be consistent with multiple pulmonary embolism. I don't think anybody in this room would have any difficulty saying that. However, sometimes it's not so easy. Here we have a defect in perfusion. It looks like it's the size of a segment. So could that be a segmental pulmonary embolism? But when we do the ventilation, we can see the ventilation defect is larger than the perfusion. So this is probably a parenchymal lung problem. Most likely in somebody that's fairly young, this may well be an acute viral chest infection, for example. So this one, subtle changes, but again, I'm sure that if I had this in the examination tomorrow, most of the trainees would be able to say that this is not a pulmonary embolism. So we always do some constant reviews. So these are some reviews that we did at the Royal Free Hospital. And I think Dr. Akhtar helped with this, didn't you? Yes, you did. I found this slide and you helped do this audit for us. So we looked at around about 300 patients who had planar VQ lung imaging, and we found that our equivocal rate was around 12%. So those 12% went on to have CTPA along with some of the patients that they decided to do CTPA on. But you can see that what you've managed to do by having a good and consistent service is that 2/3 of the patients did not need to have CTPA. They could be managed perfectly well in nuclear medicine by VQ lung scanning. But the question is, could we get that equivocal rate down further? And we'd really reached the limit of what we could achieve with planar imaging. So SPECT VQ became the next thing, and this was all developed by Professor Balic, who works in Sweden, and she did multiple studies published in the late 2000s, early 2010s, and she was able to reduce that equivocal rate from around 13% down to about 5%. And particularly she noticed a big improvement in sensitivity compared with CTPA. So if you look at some of the published data, particularly from things like the horrendous PIOPED studies in the US, they will say that PE only works in 60% of patients. If you do your test properly and use proper criteria for diagnosis, which is what Professor Balic did, you can get that up to 95%. But it is technically more difficult than planar. There will be a higher radiation dose of using krypton because you need the patients to breathe in for longer. However, that radiation dose may not be much worse than CT. Now you can do it with aerosols, but you really do need to make sure that you clear the aerosol before you do the perfusion. So you may be talking 2 20-minute acquisition and a 1-hour gap between. So that means the patient will be in your department for just under 2 hours. And that's quite a considerable period of time taken to get a diagnosis. But for many places, they find this a very useful test. So this is from the paper that was presented in the guidelines in 2009. Now you may say, are there any newer guidelines? And the answer is no. So this is the most recent E&M guidelines on lung perfusion VQ. And here you can see these are not planar images, these are coronal slices. And you can see quite a small defect there, which is probably subsegmental, which you can see in the right lung when they put a very nice arrow on for you. And when you look at the CTPA, there is indeed a subsegmental embolism. So we can start to pick up with more certainty much smaller pulmonary emboli. So for many places, this has now become the standard test in nuclear medicine for pulmonary embolism, and would expect most centres in patients who can tolerate lying down for 20 minutes or so to do a SPECT VQ and not a planar VQ. This is one of my patients, and here you can see this patient, the top line is the perfusion, the middle line is the ventilation, at the bottom is the two images merged, and you can very nicely and clearly see that in the left lung there's a nice big defect there, and on the right lung there's a subtle small defect, and there are defects in both lungs. So this again should produce a very good result in terms of establishing this patient has multiple segmental and subsegmental pulmonary emboli. So what about SPECT-CT for pulmonary embolism? Well, of course, we can potentially provide data not seen on the VQ lung scan. Particularly, we can look at lung abnormalities. Patients with no lung disease, such as COPD, which we would tend to try and avoid doing VQ lung scans on, maybe we can do those patients, because those patients we can see underlying abnormalities, so we don't have to produce a report that says there are multiple defects in ventilation or perfusion. This may be due to pulmonary embolism, but could be due to underlying COPD. If we know where the COPD is causing problems, then we wouldn't have to do that kind of report. Now, obviously, we do have a breast dose from CT, but we can use fairly low dose CT, and in younger women, for example, that doesn't need to deliver a higher breast radiation dose than doing a ventilation study either with a technetium aerosol or krypton gas. In fact, do we need a ventilation study? If we're going to be looking at the lung structure with the CT, maybe we can drop the ventilation and just have perfusion, and then we can have that with the CT. And that would make everything simpler and quicker. If you have a patient come in, you can give them MAA, you can do the SPECT-CT, and they're out in 25 minutes instead of nearly 2 hours. So suddenly you become more efficient as well. But before we go down that path, we need to know, is it better, is it the same? So there have been some studies published on this. This was Roach et al. A long time ago, 15 years ago. And he tried to do a prospective study of looking whether or not SPECT-CT could replace SPECT-VQ. And again, he identified that there were advantages in looking at underlying lung disease. And don't worry, I'll show you an example in a minute. He also showed that he could overall reduce the radiation dose of the patient by not using the ventilation scan. He did note, however, that there was potential issues in image blurring, because clearly, while you're doing a longer acquisition, whilst we're doing the perfusion, the patient's lungs will be moving, whilst with the CT scan, even though you do a resting CT, there may be less movement, so you may get a bit of misregistration. That is less of an issue now, because most of us now have SPECT-CT with either 8 or 16 slice, as against the 2 slice they had at the time. Published paper from Poland 10 years ago, looked at 100 patients that they did prospectively, again looking at planar VQ, SPECT-VQ and SPECT-CT perfusion only, and they compared that with CTPA and clinical outcome. And the numbers tell the story, don't they? If you look at the sensitivity and specificity, as you move towards perfusion SPECT-CT, you improve significantly both the sensitivity and specificity. Now, the specificity is not 100%, okay, but it's still pretty good. But the important thing is the sensitivity is to 100%. That means you're picking up all the pulmonary emboli, which is what we want to do. So what about CTPA? Because somebody will say, well, radiologists still do CTPA, I can't get any scans done. Well, this was a study done in 2016 of 100-odd patients that compared SPECT-CT with CTPA. And they noticed that the SPECT-CT sensitivity as against final diagnosis was about the same. So if somebody says to you, well, CTPA is better than nuclear medicine, the answer is actually no, it's not. It's the same. Another paper published more recently from Italy, they did a review of 8 studies comparing perfusion SPECT-CT and CTPA. And they came to the answer that the SPECT-CT sensitivity compared to CTPA was 96% and specificity 95%. And statistically, that is no different from 100 to 100. So there is clear evidence that SPECT perfusion CT, if done correctly and you learn how to do it properly, is as good as CTPA. So these patients no longer need to go toddling off to radiology. They can now all be managed in nuclear medicine. Now, whilst all this data was coming out, something else happened in the world, and that was COVID. So one of the problems with COVID is that we were all told to avoid aerosols, correct? Don't do aerosol things. And of course, the ventilation image, for many people, is an aerosol image. So there was a lot of discussion. I remember there's some discussion between the Americans and the SNMI and the ENM and the BNMS about how do we get over that. And in the end, in the BNMS, we looked at all the data and we said, if you can do perfusion SPECT-CT, please do that. Only do the ventilation if you really need to do a ventilation study. And then you have to best dress up in your bunny suits and put on your special air handling hoods, and you have to completely dress up in these sort of bizarre things you had to wear during COVID. Now, there were some small studies that were done that again confirmed that by doing that approach, that you could actually ensure you had 100% accuracy. And this was a paper from Malaysia, so this could be done anywhere in the world. It didn't have to be done in America or in Europe, showing that we could, once we learned the technique, stick to SPECT-CT with perfusion. So this is the kind of image that you can see. I'm just showing you just the perfusion and the registered image here. And what you can see is that the registration is not perfect, but it's not bad. And one of the reasons is that you can ask the patient just to quiet breathe whilst you're doing the CT scan. But you can see here very nicely the advantage is you can look at the perfusion image, see where there appears to be a defect, and if you'll notice there's a little defect in the left lung, and then you can see if there's anything in the underlying CT scan. Now, not on this one because I'm just showing you the registered image, but when we start to use these images in reality, and this is a patient from Cambridge from just a few weeks ago, and here you are, you have a 25-year-old male, 3 episodes of pain and shortness of breath, no family history, no other history of anything else, just literally came into the emergency department feeling short of breath. And that was for 24 hours. And here you can see there is a slight misregistration, but it doesn't matter because clearly there are perfusion defects. You see the red arrows showing that basically within the lower lobe of the left lung there are segmental defects. And if you look at the CT very carefully, you'll notice the CT looks quite black there. And that's because there's no lung markings, because there's no perfusion of the vessels. Okay? So the vessels have collapsed because of the pulmonary embolism. But you also notice there's no other lung disease. So the explanation now, you can say, is that there are defects in perfusion at segmental size with no underlying CT to explain that perfusion defect, such as a tumor or infection. Therefore, this is pulmonary emboli. So you've gone from 13% equivocals to being able to deliver 0% equivocals. On other times, you have patients which are difficult. So this is a 70-year-old patient, female patient with a history of pulmonary hypertension. And one of the causes of pulmonary hypertension are chronic repeat pulmonary emboli. Now, this patient had a CTPA that was negative, but they weren't happy and they wanted to know were there peripheral perfusion defects. So we did a perfusion SPECT-CT. You can see, in fact, if you look at the orange colour, that the perfusion is pretty homogeneous. It's a little bit wobbly, but it's not too bad. But there are no focal defects, okay? But when you look at the CT scan, this is on lung windows, you can clearly see there is fibrosis in both lungs. So again, in a difficult patient, this gets you out of trouble, because you can say, though it's non-homogeneous, there are no segmental defects, therefore it's unlikely that this patient has had pulmonary emboli. However, the reason the patient is breathless is because of the fibrosis, diffuse fibrosis throughout both lungs. So you can get diagnostic answers very quickly. So the use of the SPECT-CT, just with perfusion, no ventilation, has enabled us to ensure the correct management of this patient. So studies are starting to work on this. There's a prospective study here that's going ahead in France, a multi-center trial, and what they'll be doing is looking at perfusion SPECT-CT to answer that question. When a patient has had a pulmonary embolism, they've been on anticoagulants, when can you stop the anticoagulants? Normally we stop at 6 months. Some patients may need it longer, so they're going to do a prospective trial to see whether or not we can use perfusion SPECT-CT to see if there is any residual perfusion defect at 6 months, and from that determine whether the patient can stop their anticoagulants or need to continue and have a further SPECT-CT 6 months later. We don't know the results yet, that's due in 2028, but it clearly shows that the confidence that the clinicians have in the study to ensure that they can now do a funded prospective trial. They wouldn't do that if they weren't confident in the results delivered with perfusion SPECT-CT. Now, you get a free CT. Now, I know you guys might not want to look at the CTs. Now, I know you guys actually can look at the CTs, but you often need to get a radiologist just to confirm things. But the one thing that we always worry about CT, are we missing any significant pathology? Particularly, are we missing a small lung cancer? And looking at these things can be quite complicated. However, this is where AI comes in. Now, we live in, most of your younger people, you live in an AI generation, don't you? If you want to know where to eat tonight, you'll go to your phone and you'll say, where's the best tower? Lamb mutton tower, I want mutton tower. Where's the best mutton tower near this hotel? And the AI will work it out and say, if you go to this restaurant that's 3 streets away, this has the best mutton tower you'll ever eat in Lahore. We use AI every day, even without knowing it. So using AI on the CT scan is a very fast bit of work that's done. So they've taught the CT scan, they taught the computer to read them with patients with lung cancers, patients without. And this was published recently in Radiology. It did show, however, that it did overcall. So you still need a human to look at the scan after because the AI, what it does, it picks up 3 or 4 lesions and it says to you, are these significant? And if they are, you then report that. So watch how AI is coming to nuclear medicine as well. So in summary, SPECT-VQ and SPECT-CT perfusion are both good methods, and if done well, deliver very good results. Ventilation agents can be problematic. If you're doing perfusion SPECT-VQ with SPECT-CT, don't need to worry about it. And it's as good as doing a SPECT-VQ scan, and it's as good as doing a CTPA. So new ideas, how can we use this technique now in monitoring patients, and the use of AI to help us read the CT scan. Thank you very much.